Good afternoon, everyone. Thank you for joining us. We're so glad you're here. Today we have with us Dr. Lipika Goyal. Lipika is an assistant professor of medicine at Harvard Medical School and a member of the faculty in gastrointestinal medical oncology at the Massachusetts General Hospital Cancer Center. She currently leads the liver cancer research program at MGH and serves as a principal investigator of multiple clinical trials in hepatobiliary cancers. Dr. Goyal has been recognized for her work in understanding clinically acquired FGFR resistance in patients with FGFR2 fusion positive cholangiocarcinoma, and she serves on many hepatobiliary cancer panels. Thank you, Dr. Goyal, for being here. We're so glad you're here for us today.
Thank you. It's my honor, Melinda. Thank you so much for having me.
Wonderful. We're good to get going whenever you want. And I know everyone sent in questions, and we'll get to those towards the end.
Okay, great. I am sharing my screen. Can you see this in presentation mode?
Yes.
Okay, fantastic.
Perfect.
Hey everyone, thank you so much for joining today. I thought I would talk a little bit about clinical trials in cholangiocarcinoma, actually, because I think one of the main questions I get when patients come to see me is, what are clinical trials? Should I do a clinical trial? I've heard I should only do a clinical trial when I have no other options left. How do I get into clinical trials? What do I do if there are no clinical trials at my institution? How do I go and look for them? What exactly is a mutation? What is a biomarker? What's a phase 1 trial, a phase 2 trial, a phase 3 trial? What is a first in human study? Should I do a phase 1 trial? So if you have any of these questions, then hopefully this talk will help you answer some of those questions. And I look forward to taking your questions at the end. So one of the things I have been so excited about in this field is just the difference between what things look like in 2008 and what things look like now in 2020. So in 2008, I was in fellowship, and this is what the landscape in cholangiocarcinoma looked like. It was like 6 little birds on a wire. There weren't a lot of people that were studying this disease. And because of that, we didn't have a lot of clinical trials. People didn't know a lot about cholangiocarcinoma. It was hard to diagnose. And patients with cholangiocarcinoma were often bucketed in with patients with pancreas cancer or another kind of primary liver cancer called hepatocellular carcinoma for clinical trials. And there weren't a lot of cholangiocarcinoma specific trials. And part of this also is because we didn't understand the biology of cholangiocarcinoma. So we weren't able to do laboratory studies to understand what drugs are going to work to help these patients. Fast forward 12 years, and this is what it looks like in 2020. There are a lot more birds flocking to the wire, and that includes oncologists that are interested in learning more about this disease, pharmaceutical companies who want to evaluate their drugs to help our patients, and also scientists who are now taking an interest in making models so that we can understand the biology of the disease and then also test drugs. So if clinicaltrials.gov is any indication of the incredible interest that has grown in cholangiocarcinoma over time, you can see that back in 2008, there were less than 50 trials on the website. And just today, I looked at this, there are 581 trials if you type in cholangiocarcinoma. And that doesn't include the trials that where if you type in bile duct cancer or you type in biliary tract cancer, it's probably even more than that for patients with cholangiocarcinoma. And so there are many reasons for this, but there are at least 2. One is that we're starting to develop more models for cholangiocarcinoma. So before, as I mentioned, patients were all bucketed in together with other patients for trials that weren't in cholangio-specific trials. And it was kind of like throwing spaghetti at the wall. We would ask our colleagues in pancreas cancer, what's working for you? Maybe we can try it for our patients in cholangiocarcinoma. But now, due to the generosity of many patients who, when we do biopsies or surgeries, they contribute their tissue to grow models. And due to the excellent work of people like Dr. Nabil Bardisi, one of the laboratory scientists at Mass General, and one of the chairs of the Medical and Scientific Advisory Board for the Cholangiocarcinoma Foundation, we're able to create models to understand the biology of cholangiocarcinoma and, as I said, to test drugs. And what we know in this field is that if you want to go fast, go alone. If you want to go far, go together. There's been a tremendous amount of collaboration between patients, oncologists, laboratory scientists, pharmaceutical companies, patient advocacy groups, so many different people working together to make a difference to help you. And there have been a series of high impact papers in big journals like Nature and Hepatology and Cancer Discovery, showing just how important and prominent a lot of these discoveries are. And one of the second reasons that we are making a big splash in interest in cholangiocarcinoma is because there are targetable alterations. And so what is a mutation? The way I describe it to people is, DNA is the instructions of life, and all of our cells have DNA, including our normal cells and also cancer cells. And sometimes there is a spelling mistake in those instructions. And we call those spelling mistakes mutations or alterations, or in some ways they're a type of biomarker. And so one of the things we really encourage people to do is to get their tumor sequenced to try to understand, do you have one of these spelling mistakes in your tumor? Do you have one of these mutations? And so what we found is in intrahepatic cholangiocarcinoma, about 40 to 50% of patients have some sort of alteration. And this is a review written by Dr. Angela Lamarca and Dr. Juan Valle over at the Christie in the UK. And we see that FGFR2 fusions, IDH1 mutations, Tract fusions, HER2 amplification, BRAF mutations, people who have microsatellite instability, these are all alterations that are highly actionable, meaning that we have drugs that we can give to help address these mutations and help decrease the growth of cancer. And so this is what the landscape of cholangiocarcinoma has been over the last several years. In 2009, we had the positive gemcitabine and cisplatin trial, which is what was the standard of care for about 10 years. And there have been many different drugs that have gone up against GemCis, but nothing has beat it. And then there were a couple of other approvals, one for pembrolizumab or Keytruda for patients who have MSI high, microsatellite instability, positive tumors. And that was across any tumor that has that. People can get Keytruda. That's about 2% of patients with cholangiocarcinoma. And then also another one, larotrectinib, for the approval for patients who have NTRK fusions. And then another NTRK inhibitor as well. And that's about, less than 1% of patients with cholangiocarcinoma. But in cholangiocarcinoma itself, we also had another positive trial that was run by Dr. Lamarca and Dr. Valle, and that was the FOLFOX trial. And that was in patients who already had gemcitabine and cisplatin. When it came time for Plan B, half of them went on FOLFOX plus active symptom control, and the other half went on to active symptom control. And the patients who got FOLFOX lived a little bit longer, and this has become now the standard in the second line. But we didn't have any drugs that were FDA approved. These were all chemotherapies that had been around for years, and nothing had been approved by the FDA. But in 2020, earlier this year, it was a big year because we had our first drug approved in cholangiocarcinoma. Now, the truth is, only about 10 to 15% of patients with intrahepatic cholangiocarcinoma have an FGFR2 fusion and could be eligible for this type of drug. But the reason this is actually really good news for the field is because now oncologists are going to get profiling for patients. Patients know they need to get profiling. Insurance companies know they have to pay for profiling. And this just blows the door wide open for discovery for new drugs in cholangiocarcinoma, because the sequencing platforms that we use today are so much better than the sequencing platforms that we used many years ago, and we're discovering new mutations and new drugs for these mutations. And as we go forward over the next 10 years, because people are going to get sequenced to see if they have this fusion, we're also going to discover that people have other alterations that we have drugs for right now in other cancers, perhaps, but then also new novel mutations that people will come to the people who take care of patients with cholangiocarcinoma and say, hey, I noticed that 5% of patients have this novel mutation. We have this drug. Can we do a trial to offer to your patients with cholangiocarcinoma? So this is really good news for the field in general, not just for patients with FGFR positive cholangiocarcinoma. I think probably a lot of people know the difference between different types of cholangiocarcinoma. I think people who are on this call probably know a lot about cholangiocarcinoma, but just to make sure we're all on the same page, there are 4 different kinds of biliary tract cancers. So can you see my cursor here? Yes, okay. So this is the liver right here. These green lines are the bile ducts or the chutes that carry the bile. Here's the gallbladder right here. Here's the stomach right here, and here's the pancreas. And so bile is a substance that's made in the liver. It helps us digest fat, things like cheeseburgers and ice cream that we all like to eat. It comes down here, and then right here is when we eat something, it digests the fat in the food that we eat. Sometimes people develop tumors in these bile ducts. When the tumor is here inside the liver, it's called intrahepatic or in the liver cholangiocarcinoma. When it's involving what's called the bifurcation or the fork in the bile ducts, that's called a Klatskin's tumor or a perihilar tumor, and that's a type of extrahepatic outside the liver bile duct cancer. And then also people can have tumors right down here in what's called the distal bile duct or the mid bile duct, and those are also types of extrahepatic cholangiocarcinoma. People can have gallbladder cancer, and people can have periambulary cancer, which is a cancer right here at the tip where the bile duct enters the intestine. And so, before we used to think of all these different biliary tract cancers as a one-size-fits-all, and chemotherapy has been effective in trials where we treat all different kinds of biliary tract cancer. But now we're increasingly recognizing that, it's not just, we can't just divide these tumors by anatomy. We also have to think of what is the different mutations they have, because they act differently depending on what kind of mutation they have. And so right now we know that about 40 to 50% of patients with intrahepatic cholangiocarcinoma have some sort of targetable alteration. We are still working on discovery for patients with extrahepatic cholangiocarcinoma, but patients with extrahepatic cholangiocarcinoma should definitely still get profiled, because we do sometimes see HER2 amplification or some other alterations that we can target. So when I think about systemic therapy, I think about it in 3 buckets. So what is systemic therapy? It's therapy that goes throughout your system. So at some level, people call this, think of it as chemotherapy, but actually there are 3 different kinds of systemic therapy. One is traditional chemotherapy, which we're going to talk about. Targeted therapy, which is those medicines that help address those mutations or spelling mistakes. And then immunotherapy. Immunotherapy is what harnesses the power of your own immune system to recognize your cancer as foreign and attack it. Immunotherapy is what won the Nobel Prize in medicine in 2018. It's what Jimmy Carter got that melted away his tumors in his brain. It's what our beloved Melinda Bikini got that has helped her for so many years. So this presentation, I'm going to mainly focus on chemotherapy and targeted therapy, because immunotherapy is another really big topic. But this is really mainly about talking about one trial per bucket to just highlight some of the terminology around clinical trials and highlight some of the questions that I was asking in the beginning of the talk. So what is chemotherapy? So drugs like gemcitabine and cisplatin, the FOLFOX that we talked about, nab-paclitaxel, irinotecan. These are all different drugs that are sort of the traditional chemotherapy that we think of. Targeted therapies are those agents that target these different mutations. And immunotherapy are things like pembrolizumab or Keytruda or nivolumab or Opdivo. There's so many different checkpoint inhibitors that those are 2 that have been tested a lot in cholangiocarcinoma. And then also adoptive T-cell therapies that are available at the NIH and other places, CAR T-cells. There are a lot of different options in immunotherapy. So let's start with chemotherapy. I'm just going to highlight one trial. So I'm going to talk about this phase 3 trial, and then later I'm going to talk about a phase 2 trial, and I'm going to end with talking about a phase 1 trial. So I'm not picking any of these trials for any reason in particular. It's mostly just for the educational value of highlighting some of the terminology. So what is a phase 3 trial? A phase 3 trial, well, let me actually start with what a phase 1 trial is and then build up. So a phase 1 trial is basically where we're trying to figure out what is the safe dose of the drug and what is the safety profile of the drug, what are the side effects of the drug. Sometimes drugs in phase 1 trials, sometimes it's the first time they're being tested in human beings, or sometimes they are drugs that have been tested in patients with other cancers and now are being tested in, for example, cholangiocarcinoma. So there are different kinds of phase 1 trials, but the main thing is they're usually to find the dose of the drug and the safety. Phase 2 trials are once you figure those 2 things out, you want to see if there's preliminary efficacy. So you want to see in a small number of patients, how well does the drug work? And there's usually some pre-specified bar that if the drug meets that pre-specified bar, then those drugs can go on to phase 3 trials. So this is a phase 3 trial that's going on right now in the US. It's the first phase 3 trial in biliary tract cancers to take place in the United States. And it's a combination of gemcitabine, cisplatin, and nab-paclitaxel compared to gemcitabine and cisplatin. So phase 3 trials basically take some sort of regimen and compare it to the standard of care. And gemcitabine and cisplatin is the standard of care right now for any newly diagnosed patients. And so one of the things that you'll hear about when you come to talk to your doctor about clinical trials are, we need to do some screening procedures to see if you are eligible. And what does that mean? We always want our patients to be safe when they're going on clinical trials, because these are sometimes new drugs or old drugs that are being used in a new way. So we have to make sure your heart is okay. We often do an EKG. We have to make sure your lungs are okay. We have to make sure your kidneys are okay. Your liver is okay. So we do all sorts of different blood tests, urine tests. Sometimes we do an ultrasound of the heart. And then we also see, what stage of cancer do you have? How much get up and go do you have? Because sometimes cancer treatments can make you tired and they can cause certain side effects. So we always get a sense of how much get up and go you have. That's what the ECOG performance status is. So there are a whole series of different eligibility criteria. We assess patients and make sure that they're safe for the trial. One of the things that Melinda and I are working on right now is to try to figure out how can we advise the pharmaceutical industry and how can we advise people who are designing trials how to have slightly more liberal but still safe eligibility criteria for clinical trials so we can let more patients in while still keeping them safe. And that's something that we're working on to basically expand access for patients. The next term is randomized. What's a randomized trial? A randomized trial means that a computer decides which of the two arms do you go to. Do you go to the triple therapy, the gemcitabine, cisplatin, nab-paclitaxel, or do you get into the gemcitabine, cisplatin arm? The oncologist doesn't decide. A patient's name goes into, or a patient's number, actually, because everything is anonymous when it goes centrally to companies. And a computer decides which arm you go to. And sometimes you know which arm you're going to be on. Sometimes you don't know which arm you're going to be on. And that's a good question to ask your doctor before you sign up for a trial. And there are 1-to-1 randomized trials, 2-to-1 randomized trials, and 3-to-1 randomized trials. A 2-to-1 randomized trial means that 2/3 of patients get into the experimental arm, in this case, the triple therapy, and 1/3 of patients go into the standard arm, gemcitabine and cisplatin. A 1-to-1 randomization means you have a 50-50 chance of going into either of these trials. So this is being run by Rachna Shroff from the University of Arizona. I think many of you know her. She is leading this trial through the cooperative groups. And Mitesh Borad, Laura Goff, and Jason Starr are all champions for this trial. I think this has the chance to change the standard in cholangiocarcinoma, because we've been using gemcitabine and cisplatin for many years, and people certainly get benefit, but we need to do better. And we hope that one of these clinical trials that we have in the front line, and there are many of them going on right now, we hope that one of them helps get us better outcomes for patients besides what GemCis can do. So a lot of the trials are GemCis combination trials, actually. So let's talk about targeted therapy. So as I mentioned earlier, we used to divide biliary tract cancers by anatomic location. And now with tumor sequencing, we've learned that people have different kinds of alterations depending on what kind of cancer they have. And the Cholangiocarcinoma Foundation has put together a wonderful campaign called Mutations Matter. And that's for all of you to recognize that it's really important to talk to your doctor about getting your tumor profiled. Sometimes hospitals do this within their own hospital because they have their own platform. Sometimes they send the tissue to different companies that do this as well. And basically it helps us understand what can we do for plan B. Sometimes it can even be helpful for plan A, because more and more we're trying to think about what are ways that we can spare patients chemotherapy. So if you get your profiling done up front, and if you happen to have, for example, an FGFR2 fusion, there are now trials where you can go into a trial where you can either get an FGFR inhibitor or you can get gemcitabine and cisplatin. Again, it's a computer that randomizes. But more and more, as we discover these different alterations and get better drugs, we're going to try to move these targeted therapies into the first line as well. and maybe even before surgery, because there's some patients that have a tumor that's almost resectable, but it's not quite resectable because it's kissing a blood vessel or stepping on the bile duct, and we're not able to quite get the tumor out. And so if we can give people targeted drugs or chemotherapy or immunotherapy, something that helps shrink the tumor, then we have a better shot of getting someone to surgery and getting them to cure. So for everyone who's on this call who is trying to figure out what are the next steps for cholangiocarcinoma, I hope everyone has had their tumor profiled. If you don't know what that is, certainly talk to your doctor about it or reach out to us at the Cholangiocarcinoma Foundation, because we're happy to talk to you about it more. What are the potential benefits of targeted therapy? So chemotherapy is a great option for a lot of people because it helps kill cancer cells, but there's also a lot of collateral damage with chemotherapy where a lot of good tissue can get damaged. And so the whole goal of targeted therapy is to have like a laser focus just on the tumor cells that need to be killed and not on normal cells like hair cells and the stomach lining cells and nerve cells, for example. So if you can tailor it, then you have the potential to offer the right drug to the right patient for the right disease at the right time with the right dose. It doesn't always work out that perfectly, but that's certainly the aim of what we're trying to do with targeted therapy. And the potential benefits are improved outcomes for patients, because if we know what mutation they have, we have a drug for that mutation. Instead of it working only in maybe 10 to 15% of patients, we can increase that to 30%, 60%, hopefully even close to 100% of patients if we can get smart enough to figure out how to match patients with the right drug. We can minimize side effects. We don't want any of our patients getting a drug that doesn't work. And so if people are getting drugs that are not matched to their tumor, sometimes they have unnecessary side effects. Reduce cost of clinical trials. If you can get your answer with 40 patients as opposed to having to do it with 250 patients, that means that drug gets approved by the FDA sooner. And so if we can actually minimize the number of patients that we need to show that a drug works, that's good for everybody around. And then, as I mentioned, getting faster to drug approval. There are a couple of different types of trials when we think about how to do targeted therapy trials. So one is a target-specific cholangiocarcinoma trial. So when you have some sort of alteration that's in high enough frequency, you can do that trial specifically in patients with cholangiocarcinoma. So those are things like IDH1 mutations, which you see in somewhere between 15 and 20% of patients with intrahepatic cholangiocarcinoma. FGFR2 fusions, which I already mentioned, you see in 10 to 15%. Those are high enough frequency that these are cholangiocarcinoma-specific trials. Sometimes patients have alterations that are more rare, such as BRAF or NTRK or microsatellite instability. And when people have those more rare mutations, we sometimes do basket trials. So basket trials are more like there are many different tumor types, but there is one special cohort for patients with biliary cancer or cholangiocarcinoma. So these different alterations are usually seen in about 2 to 5% of patients. And then lastly, there are umbrella trials where they're all in patients with cholangiocarcinoma, but you have target-specific arms. And so there are different kinds of efforts that are going on to have umbrella trials in cholangiocarcinoma as well. So I'll now talk about a little bit about tumor mutational profiling and then a phase 2 trial that highlights some of the language around phase 2 trials that might be helpful. So what are we looking for when we do mutational profiling? We're basically looking for some abnormality in the DNA. And in the simplest terms, there are about 3 different kinds of alterations. They're fusions, they're mutations, and they're amplifications. Fusions are often where there's some sort of abnormality in the chromosomes, where one piece of a chromosome gets stuck to another piece of a chromosome. Sometimes there's chromosome 1 gets stuck to chromosome 10. Sometimes it's 2 pieces of the same chromosome that flip upside down and reconnect to each other. Then there are mutations where there's one amino acid change to another, often is one type of mutation. And then there are amplifications, which there are many copies of a certain gene. Basically, all of these lead to cancer growth in some way. And so the goal is to shut down the pathways that are activated by these different alterations. And so one study that has been trying to address this is the phase 2 study of Futibatinib, which is a covalently binding irreversible FGFR inhibitor. And so some of the things to highlight here are, again, looking at eligibility criteria. So something on this slide is this idea of measurable disease. What is measurable disease? It's basically having a tumor that is large enough to be able to be measured by the radiologist and followed on each scan. You know, sometimes people hear on their scans when they say to their doc, how much did my tumor shrink? And sometimes the doctor will say a specific number like 20% or 40%. How do we figure out if people are responding? So what we do actually is we take 2 measurable lesions in each organ, up to 5 organs, and we follow those 10 lesions over time. If someone has 1 lesion, we follow that 1 lesion. If they have up to 10 lesions, we follow the 10 lesions. And we just measure the largest diameter of that lesion over time. And then we sum up the different diameters of those lesions and we get a number. And then we follow those lesions over time and we see how the sum of the diameters of the lesions changes. And that's how we come up with whether or not someone is benefiting from treatment. If that number is increasing, we worry the tumor is growing. If the number is decreasing, then we are glad that the tumor is shrinking. And that's how we standardize across trials, and that's why the measurable disease is important. But we also know that people with certain kinds of cholangiocarcinoma, like perihilar or Klatskin's tumors, sometimes don't have measurable disease. So one of the things Melinda and I are also working on is which trials do we really need measurable disease in, and which trials do we not need that, again, to try to gain access for patients. The other thing we think about is this a trial that's open in only one institution, or is it a multi-center trial? Is it a open label study where you know what drug you're getting, or are there 2 arms where you're not sure what arm you're going to be going into? Is it a trial that's only in one country, or is it in many countries? All of these different things are the way we think about trials, because we basically want to get as many people access as we possibly can. So in this trial, the Futibatinib trial, about 60% of patients were women. It was done across many different regions, so North America, Europe, Japan, and Asia. We looked at how many prior lines of therapy people had. About 45% of people had 1 prior line of therapy, but there were a lot of people who went on this clinical trial who had at least 3 lines of therapy. That was 27%. And then this is what we do with the data when we do the measurements of the tumors. We see how much tumor shrinkage did people have. And that helps us figure out, is the drug working? Because, you know, the gold standard with clinical trials usually to get FDA approval is, did it help people live longer? But we don't want to have to wait to figure out what the median survival in the trial is to get drugs approved, because that means we sometimes have to, luckily, wait a long time because we're doing survival as opposed to just figuring out, is there tumor shrinkage? And what we've learned over time is that if you use tumor shrinkage, if the tumors have shrunk a significant amount, that can sort of be a surrogate for understanding, okay, this drug probably has activity, and companies can go to the FDA and say, okay, we're not going to look at survival, we'll look at that sort of in the long term, but look, this drug shrinks tumors in about 35–40% of patients. So we think this is active. It would be great if we can at least get preliminary FDA approval while we're doing bigger studies to prove that this drug works. And so in this type of graph, basically each bar is 1 patient. And you can see people on this side had significant tumor shrinkage. Anyone here, this dotted line is 30% shrinkage. So anyone here had more than 30% shrinkage right here. And people on this side, unfortunately, had some tumor growth, but this is what we call a waterfall plot. And this is how we see how much did people benefit from this drug. And then the next thing is duration of response is something that we look at. And this is important because, again, one of the things the FDA looks at is, okay, you're saying that 30–40% of people had tumor shrinkage, but did it last? And now the FDA is very kindly allowing drugs to get approved if you can show not only did the tumor shrink, but that it had a reasonable duration of response as well. So what percentage of people, when the tumor shrank, did it last for at least 6 months? So in this trial, the median duration of response was 6.9 months. And so this is how sometimes when you just have a single arm study, these types of drugs can sometimes get approved by the FDA, and that's what happened with pemigatinib. And then the other thing we also think about and take very seriously is what kind of side effects are patients having on these drugs? Because we want your quality of life to be very good. And so we have a grading system for how severe the side effect is, grade 1, 2, 3, 4. So you'll notice whenever you come into the office, doctors will always ask, okay, what kind of side effects are you having? Are you having any nausea? Are you having any diarrhea? Are you having any numbness in your fingers and toes? Because we want to be able to troubleshoot and help you feel better. So it's really important. You're never bothering us. I always tell my patients, never worry alone. If you're ever worried, if you're ever nervous, if you're ever having any kind of side effects, call us anytime because we can help you troubleshoot and get you to feel better. And then we can use these kind of data to help signal to oncologists when they use these drugs, what are the different side effects? And the oncologist can also counsel patients to figure out, okay, you're going to have a 30% chance of having mild nausea. You're going to have a 5% chance of having severe nausea. That's the kind of information that we gather on clinical trials. And the key is we're always trying to help people have a better quality of life with whatever we're doing. And this is my last trial that I'm going to talk about. And this is a phase 1 trial. So the language to know about phase 1 trials is dose escalation and dose expansion. So something I often hear is, I don't know, Dr. Goyal, I'm not sure about a phase 1 trial. I hear those are like end of the line trials. And I hear that, you know, you're really a guinea pig when you do a phase 1 trial. What do you think about phase 1 trials? And what I always say is that any drug that gets approved by the FDA, 1 trial, it has to start in humans for the first time. And there are drugs that are very promising that enter phase 1 trials and go all the way to phase 3. Now, yes, it's absolutely true that there are drugs that get tested in phase 1. They don't end up being very effective and they don't move to phase 2 and then don't move to phase 3. But it's also true that sometimes when drugs don't advance, there are individuals within trials who are super responders who get a fantastic response. And phase 1 trials now are a lot different than they were, let's say, even 5 years ago, 10 years ago, because now we're doing smart trials. We're doing biomarker selected trials. So we're not just, again, throwing spaghetti at the wall. Very often there's preclinical data, meaning data from the laboratory, often from cell lines or mice, looking at why this drug works. I know for myself, when I'm thinking about opening a phase 1 trial at Mass General, I always ask the company, what does your preclinical data look like? What is the activity that you have in the models to give us an inkling that this is going to actually work in patients? And it's worth putting people at risk for a new drug, you know? And so the phase 1 trials, I think now, because they're often biomarker selected and there's preclinical data, the response rates, and there was an article in New England Journal of Medicine about this, the response rates are higher than they used to be. And so I'm very excited about a variety of different phase 1 trials that are going on in this country right now. And I think it's worth exploring what the options are. And I don't think of phase 1 trials as the end of the road. I often will put people on a phase 1 trial as plan B. You know, they're on gemcitabine and cisplatin and the tumor starts to grow and it's time for plan B. You know, I could do FOLFOX or I could do, you know, a different trial. But if there's a really exciting agent in phase 1, then I certainly offer it to people. So what is dose escalation? Dose escalation means they're trying to figure out the right dose. And the most common approach to that is, let's say you're going to start at 1 milligram. They'll put 3 patients at 1 milligram. If all of those patients do well, then they'll go to 2 milligrams and put 3 patients at 2 milligrams. If all of those patients do well, they'll often go to 4 milligrams and put 3 patients there. And then let's say one of those patients has a significant side effect. The question is it something specific to that patient or is it something that we should worry about with the drug? So they'll often put another 3 patients at that same dose level of 4 milligrams. And so they'll have 6 patients total. And then they'll figure out, okay, there was only 1 patient out of 6 that had a side effect. We'll go up to 8 milligrams and they'll keep dose escalating. But if 2 out of 6 patients end up having a bad side effect, then they think, you know what, I think this is probably the highest we can go. And that's how they help figure out what's the right dose for the drug. And these trials sometimes will test a dose of a drug, sometimes will test a schedule of a drug, like maybe the drug should be given twice a day instead of once a day, or it should be given 3 times a week. So this is basically where we follow people very closely. Phase 1 trials are often quite intense in the first month because we're trying to really understand how patients are doing on the drugs, and we're trying to understand how the blood is processed, what the levels of the drug are in the blood, and also what the drug is doing to the body. And all of that requires, a bunch of blood tests and a bunch of very close monitoring. So we totally recognize that it's quite an imposition on patients to come back several days in that first month. Sometimes there's a lot of blood tests. Sometimes there's an extra biopsy. I can say honestly that a lot of it is to try to help understand how the drug is working so we can help patients in the long term. But we appreciate all the effort and energy that it requires to be part of phase 1 trials. After dose escalation, we figure out the dose and we go to dose expansion. And that's often specific cohorts, sometimes of specific tumors, sometimes of specific alterations. And this looks at how well does this drug at 8 milligrams work in these 5 different populations of patients. And we get a preliminary signal to try to understand, is this drug worth moving forward to a phase 2? And out of these 5 cohorts, maybe 3 of the cohorts, patients have great responses, and those 3 cohorts move on to more phase 2 testing. Or sometimes in dose expansion, we don't see any activity, unfortunately, and then the trial doesn't go to phase 2. But we try to keep phase 1 trials oftentimes small to really get a sense of how the drug is working. But sometimes if the drug is very promising, they expand to have more cohorts to really give more access to patients. This is a FGFR2 specific drug that is by the company Relay. It's a first in human study. So sometimes, understandably, people are a little nervous about doing a first in human study because it's the first time a drug is going into humans. But I will say that there is a lot of strict guidance around studies that have to be done before drugs go into humans. Unfortunately, a lot of those studies are done in animals, but it's the way that we can try to keep it safest for human beings. So they're often done in small rodents and then sometimes in non-human primates, like monkeys. And it's really just to figure out what is the safety profile of drugs before we put that dose in humans. And then we'll often use like 1/10 of the dose that we use in animals when we put it in humans. And then we slowly go up on the dose to figure out what is the best dose for patients. And, as I mentioned, we look at preclinical activity, and we also look at what populations are going to benefit the most. Does it make sense, for example, to give this drug to people who have never had an FGFR inhibitor and have also had a prior FGFR inhibitor? The preclinical data for this drug shows that it can likely overcome some of the resistance mutations that occur in the setting of other FGFR inhibitors. So for this trial, it does make sense to give it to people who have had a prior FGFR inhibitor and then the tumor has grown. And so these are the different things that we think about as we design phase 1 trials. And so finally, I will just say that there's a lot of hope in clinical trials for cholangiocarcinoma. There are 10 times more trials now than there were 10 years ago for patients with cholangiocarcinoma. And that doesn't even take into account all the basket studies where there are cohorts for patients. Mutational profiling can open up treatment options. So it's really good to seek out mutational profiling and talk to your doctor about it. And then, some patients don't have mutations that we can take action on, and that's okay because there are many trials that exist that don't require a specific tumor mutation or a biomarker. And then finally, I would just really encourage you to find out about options for clinical trials. There may be clinical trials at your institution, or there may be trials at other institutions. And actually, one of the things I wanted to talk to Melinda about is because I know you talk to so many patients who are interested in clinical trials. After all this, I would love to hear from your end about how do you connect with clinical trials? What are the best resources to connect with clinical trials? But thank you very much. That's all I have.
Thank you. That was wonderful. I will throw out to the audience that you are more than welcome to put questions in the Q&A box or the chat box. And I'll just emphasize to keep those questions, I don't know that I want to say non-clinical, but Dr. Goyal is not able to give medical advice over the webinar. So questions that are just, I guess, general to the population that, that can be answered here. And I will start with a few if you're ready.
Sure.
Melinda, But
Yes.
I apologize, but I wanted to let you know, it appears that we're having some difficulty with getting questions into the Q&A box. There's only one question there, but there are several questions in the chat. So 2 places to look. Thank you.
Got it. Thank you. Okay, so a couple things that I wrote down as you were speaking is, can you talk a little bit about endpoints and what that means in clinical trials?
Yeah, sure. So for phase 3 clinical trials, it's usually survival, because for something to get approved, like get full approval by the FDA wants to know that it's going to help people live longer. So that's the gold standard. That's what overall survival is for a lot of phase 3 trials. But for phase 2 trials, the bar is often different. It's something like objective response rate. So that's what I was talking about when I said people need to have measurable disease. We follow somewhere between 1 and 10 lesions over time. We see if people have had tumor shrinkage. If you've had at least 30% tumor shrinkage, it's considered a partial response. And so we figure out what's the response rate. And so if that's what the primary endpoint is, sometimes for a trial to be positive, the trial statistics will say we need 30% of patients to have a partial response for this trial to be considered positive. And sometimes, these surrogate endpoints like response rate or progression-free survival, these can be used to get FDA approval. It's usually what's called accelerated FDA approval. This is what Pemigatinib got, which is approval with the hope that a larger confirmatory phase 3 trial will show a survival benefit, and then the FDA will give full approval. So it's basically for us to figure out, did the drug work well enough for it to move to the next phase or to move on to FDA approval?
Okay, wonderful. And some of the questions that were submitted, I'm going to go through and try to ask the ones that you're able to answer. Can you touch a little bit about neoadjuvant therapies?
Yeah, so, we want to get as many patients to surgery as we can. Sometimes people's tumors are, it's all about real estate with cholangiocarcinoma. Sometimes the tumors are, as I was mentioning, kissing a blood vessel, wrapping around a blood vessel, or just in some area where it's really hard for the surgeon to get a negative margin. When you do surgery for cholangiocarcinoma, you generally don't want to leave a positive margin. You don't want to leave cancer behind. And so surgeons want us to do everything we can as medical oncologists, radiation oncologists, interventional radiologists to try to shrink the tumor and give them the best chance of a negative margin. And so that could be in the form of systemic therapy, such as targeted therapy, chemotherapy, immunotherapy, try to shrink the tumor. It could also be in the form of radiation. It could also be in the form of things like Y90 or other interventional radiology techniques that can try to shrink the tumor. But the goal is to shrink the tumor to try to get someone to surgery.
And then let's just throw in adjuvant therapy after surgery.
Yeah, so, surgery is definitely our best shot at giving someone a shot at cure. After surgery, people can be in one of 3 buckets. One, the surgery cured them. They're never going to hear from the cancer again. And we can give them chemotherapy after surgery, but that chemotherapy just causes side effects and doesn't actually give that patient any benefit. And then there's patients in the second bucket who they had the surgery. There's still 10 cancer cells that are floating around. You give them chemotherapy, you mop up those 10 cancer cells, and I just used 10 cancer cells to pull a number out of the air, but it's microscopic metastatic disease. The chemotherapy kills it, and you've converted this patient from not cured to cured. And that's sort of the best case scenario for where adjuvant therapy is making a difference. And the third scenario is patient has surgery, they have 100 cancer cells floating around, they get chemotherapy, and the chemotherapy is not able to get rid of those microscopic cells, and eventually the cancer comes back. Now, sometimes the adjuvant therapy might push back the time it takes for the cancer to come back, but the chemotherapy didn't actually cure the patient. There's now, a new interest in doing blood-based biomarkers after surgery to figure out who needs chemo and who doesn't. There are efforts through the Cholangiocarcinoma Foundation to assess that in cholangiocarcinoma, but there are a lot of efforts in some of the more common cancers like colon cancer, breast cancer, lung cancer, where they're using ctDNA or circulating tumor DNA analysis to figure out who should get chemotherapy and who should not. Those are all in clinical trials right now.
Wonderful. All right, I'm going to ask, do you have any information on any research being done on KRAS mutations? And there was more than one question about KRAS featuring all the G12, G12C, all those variants.
Yeah, there are a lot of new inhibitors. KRAS is one of the most common mutations seen in cancer. So there's been a lot of interest to try to be able to drug it. So yep, I don't want to name one company in particular, but there are multiple companies that are doing trials with KRAS inhibitors. So it's certainly, if you have a KRAS mutation, it's worth talking to your doctor about clinical trials.
Okay, that's good to know. There's a lot of questions also asking about the FGFR mutations, and when you fail the first targeted therapy, how do you know which one to move on to? Is there an order to move on to? And those kind of questions.
Yeah, it's a great question. We're still learning. We're still learning that when people get the first FGFR inhibitor and the drug fails them and they need to go on to the second FGFR inhibitor, which one to choose. You know, we've done some work preclinically showing what the spectrum of activity is of different FGFR inhibitors against different mutations. Dr. Samik Chaudhary and Melanie Crook have also done some of this work at Ohio State. Again, just looking at what drugs work against what mutations. So, you know, that's laboratory work. It's the best we've got right now. So that can help guide. And now we have clinical trials of drugs that potentially can overcome some of these resistance mutations. So I think if people are near institutions where they have access to clinical trials, I think that's also a good option.
Okay. I think you touched a little bit on this, comparing chemotherapy side effects to targeted therapy side effects and more severe, and if one has a more long-term results over the other.
Yeah, that's a great question. I would say that every patient is different, and it's so hard to predict upfront who's going to have what side effects. I would say with chemotherapy, and Melinda, I would love for you to chime in about this because, you know, I see it from one side and you see it from another side. And actually, why don't you go first and I'll go second? I feel like you're...
Well, I definitely see, I think, less severe side effects with the targeted therapies. And I do see patients having better quality of life on targeted therapies versus chemotherapies.
Yeah, I think as a general principle, I think we often do see a bit more nausea and fatigue and some other side effects on chemotherapy. That being said, because I know some patients are not candidates for targeted therapy, I have patients who have been on Gemcis for more than a year, and they say, "Doc, are you giving me water? Because I feel fine," you know?
Yes. That is very true. And I am a patient who did horrible on Gemcis, so it's hard for me to remember, but you're right. I talk to patients all the time who also are in chemotherapies for long term. I think it's so individualized that, you know, it depends on the person.
And the key is like never suffer alone. So if you're having nausea, we have lots of tricks up our sleeve. If you're having diarrhea, we have lots of tricks up our sleeve. We want to keep our patients out of the hospital. So if you tell us early, then, you know, we can troubleshoot with you over the phone, or we can bring you into clinic, give you some hydration. We can do a lot of things to improve your quality of life. Chemo doesn't work better if you're suffering, you know, it works better if you're like eating, enjoying your family, and, you know, having a good quality of life.
Exactly. Okay, there are a lot of questions. I'm going to try to get to as many as I can. Is the preclinical data for the Relay 4008 available for patients to read?
You know, I think whatever data are publicly available, you can go to their website to see what kind of data are publicly available, but I think there's going to be more data that comes out over time.
Okay. And if the doctor or institution does not offer tumor profiling, can a patient request privately through a different organization?
That's a great question. Melinda, you might have the answer to that one.
Yeah, I think a doctor still has to order the test, but there are there's some different options right now. Target Cancer Foundation is running a clinical trial on patients who need to get genomic profiling or biomarker testing done. That's one way to get it. And then also through our
one tiny second, I'll be back in 1 second, sorry.
And then also our Mutations Matter campaign that we have, the Biomarkers Matter. Perthera, there's the link on our webpage, the Perthera link. They will help facilitate to get your biomarker tested order through your physician. So they'll help be the concierge service, the middleman to get that test ordered. I hope that
I think most oncologists are on board with the idea of getting profiling because it definitely helps us give people more options. So it's definitely worth having a conversation.
Okay, question on, are there any treatments for BAP1 deletion?
That's a good question. I would say that it would be helpful to tumor suppressor gene. It would be helpful to get a sense from people's phase 1 groups, whether or not your institution has any options for that specific deletion.
Okay. What is the average longevity or efficacy of GemCis working before it doesn't work anymore, or if one becomes allergic to it?
Yeah, I usually give people a range, and I would say GemCis usually works for between 6 and 18 months. That being said, all of us have had patients who have been on GemCis for longer than that, but I would say on average it works for between 6 and 18 months. Oh, sorry. Sorry. What's the longevity on it? Let me try that again. How long do people? Okay. I think, how long does GemCis work? Sorry, it works probably between like 4 and 10 months for people. Yeah, that's about how long it works for people, between 4 and 10 months.
All right, sounds good. So about measuring tumor size, I think the RECIST criteria, can tumors be killed by the chemo without shrinking very much? And how is that accounted for in measuring a response?
Yeah, can you just say that one more time, sorry?
Yeah, so when you measure tumor size, I think they're referring to the RECIST criteria. Can tumors be killed by the chemo or the treatment without shrinking very much? And then how would that be accounted for in measuring that response?
Yeah, that's a great question. RECIST criteria are not perfect, and certainly scans don't give us the full picture on are the cancer cells dead or not. The only way we can figure that out is if we take out that tumor and look under a microscope and see are the cells living or dead. And so RECIST is an imperfect but very good system, I would say. And we need to have some standard way to look across tumors. And so sometimes tumors that are dead, they enhance less, so they light up less on scans. And that's one way that we can tell that the tumor looks like it's dying over time. So, there are certain tumors where it doesn't shrink, but it lights up less, and so we just use our best clinical instinct, which is a combination of what the scans show, how a patient is doing, and also biomarkers like CA19-9. But the truth is, on trials, even if you don't technically have tumor shrinkage, even if your tumor is stable, and let's say it's stable for 1 year or 2 years, you still get to stay on trials if the tumor is stable, So I always tell patients, like for gemcitabine and cisplatin, about 25% of patients have significant tumor shrinkage and about 50% of patients have tumor stability. And so I always prepare patients for when we're going to look at our first scan that actually tumor stability is success too. That is victory too, because if you could get 1 year of tumor stability or 2 months of tumor shrinkage and then it grows again, I think most patients would be okay with 1 year of tumor stability because it means the cancer is not growing or spreading, And
Exactly.
So understanding what victory looks like is important so you feel happy when the scan comes back as stability. I mean, we all want tumor shrinkage, oncologists, we all want tumor shrinkage for sure. But I always want my patients not to feel disappointed also with stable disease, because that stable disease can last for a long time and we'll take that,
Right. Stable is good for sure. What about any new treatments targeting HER2 and the ERB2 mutation?
Yeah, this is a space that's really lighting up, both because of breast cancer and also stomach cancer, esophagus cancer, where the rates of HER2 amplification and HER2 mutations are higher. So there, again, I don't want to mention one company in particular, but there are many different HER2 inhibitors, both oral small molecule inhibitors and also IV drugs. There are combinations of HER2 inhibitors with immunotherapy. There's combinations of different kinds of HER2 inhibitors, lots of different drugs in this space. So definitely worth reaching out.
Yeah, and I'll just put a plug in. I think January's webinar is going to be about HER2 mutations. So tune in for that.
Fantastic. Fantastic.
Okay. So can you give us, I guess, how do you work alternative treatments in with regular treatments, like vitamin C infusions, oxidative therapies, insulin potentiation therapies, those kind of things?
Yeah, I think that we certainly don't have all the answers in medical science with chemotherapy and with targeted therapy. And I think that there are alternative therapies that can really benefit patients. I would say that there are things that can help and there are things that can harm. And, sometimes there are not a lot of data to help guide us as to what's helpful. Sloan Kettering has a great alternative and complementary medicine website that has, you can look up things like milk thistle and different things to see what are the data that are out there in terms of what are the organs it can affect, what are the side effects, what can it interact with. I would say it's always good to talk to your doctor, your nurse practitioner, your clinical team to mention that you're interested in these therapies, and are they concerned about any drug interactions with the radiation that you're getting, with the chemotherapy that you're getting, with the immunotherapy that you're getting. I will say when people are on clinical trials, there's often a request not to be on any of those types of alternative therapies that you ingest, things like massage and acupuncture, those are often okay. But there's a concern that maybe some of the drugs can, like for example, St. John's wort certainly interacts with a bunch of different oral therapies. So it's always worth discussing it with your oncologist.
Thank you. Okay, so there's a couple questions about BRAF mutations and the treatments that are out there for those.
Yeah, so there was the ROAR2 study that was trametinib and dabrafenib, so a MEK inhibitor plus a BRAF inhibitor. There's the vemurafenib study, which is a BRAF inhibitor. And there are multiple new studies that are coming out about BRAF inhibitor plus immunotherapy and different combinations. So I think there are also a lot of trials out there for BRAF mutant tumors that, again, it's worth talking to your doctor. I believe dabrafenib, trametinib made it onto the NCCN guidelines. And so outside of a trial, I think that could be an option to get access to.
Wonderful. Okay, so a question about the FGFR mutations. So for patients who have FGFR and have had certain kinds of metastasis like lung, bone, etc., would one benefit less, and should they consider other options? Does the metastasis location make a difference?
That's a good question. I'd say right now we don't have any data specifically that says if you have a lung tumor, metastasis in your lung or your liver or your bone or someplace in particular, that you're not going to respond to an FGFR inhibitor. So I would say no, where the metastasis should not impact whether or not you think about going on to an FGFR inhibitor.
Okay. There's a lot of questions on immunotherapy, and I know you didn't touch on that, but are there any trials out there you would mention or treatments other than the MSI high patients and mismatch repair?
There are a lot of trials that are chemotherapy plus immunotherapy. So there's gemcitabine, cisplatin plus PD-1 inhibitors, PD-L1 inhibitors, gemcitabine, cisplatin plus PD-1 or PD-L1 plus VEGF inhibitors. So there's a bunch of trials in the first line. And then there are trials in the second line that are combining PD-1 inhibitors plus CTLA-4 antibodies, that by itself, or for example, in combination with radiation. There are also trials that are looking at novel immunotherapies that are, for example, bispecific antibodies against two different checkpoints, or bispecific antibodies against two different targets, such as like HER2 and PD-1. So there are lots of different options for people that are looking for immunotherapy trials. And you don't often have to have a biomarker, so you don't have to have microsatellite instability. Majority of them do not require PD-L1 expression. It's something that they'll test on your tumor tissue, and then out back, they'll see, okay, were there higher responses in people who had PD-L1 expression? But generally speaking, they're not usually biomarker selected.
Perfect, that's what I was gonna say. And that brings us to the end of the hour, and I know that went by so fast. I know there were a lot of questions that didn't get answered, but we will take note of all these questions, and I will do my best to gather answers and send them back to everyone. I appreciate everyone chiming in and sending in your questions and joining us. And this webinar is recorded, and Rick will have it up on the Cholangiocarcinoma Foundation website and our YouTube channel as soon as possible. Thank you so much, Dr. Goyal, for being here. You always do such a wonderful job. We appreciate you so very much.
Oh, always a pleasure. Thank you for having me, Melinda. It's always my honor.
Thank you so much. You have a wonderful day and weekend, and Merry Christmas if I don't see you sooner.
Thank you. You too. And to everyone out there.
Thanks.
Happy holidays.
Have a good day.